We're going to talk a little bit about sepsis and EMS's role in treating sepsis, some of the pathophysiology of sepsis, and just sort of a good overview of sepsis. And we're hearing more and more about sepsis, and sepsis has been around a long time. It's not a new phenomenon. It's just got a renewed interest in treating the sepsis and hopefully what we're doing, and it is reducing the mortality from sepsis. And sepsis is something that is usually related to an infection, and what happens is this infection sort of triggers an immune system response in the patient that is an exaggerated immune system response. And we're going to talk a little bit about that in a few minutes. This exaggerated immune system response causes inflammation, which ultimately affects in-organ manifestation or in-organ function. So it's not just your typical infectious or inflammatory response. It's a sort of an exaggerated inflammatory response. Sepsis has a high mortality rate. Some people say up to 40%, and they're variable clinical presentations. So not every septic patient is going to present in the same manner. It's going to be a variable presentation. So you really have to have a high index of suspicion in order to catch the septic patient. And we'll talk a little bit about that in a few minutes. Many times, especially in the pre-hospital arena, sepsis is under-recognized and under-treated. So again, we're going to go back to that overwhelming theme of high index of suspicion during this talk. As I mentioned, mortality rate can be 10 to 40%. Many people will tell you that if the septic patient becomes hypotensive, once they become hypotensive, then that mortality rate is going to skyrocket and can be up to 40%. So what we try to do is keep that patient from becoming hypotensive, and we're going to talk about that in the treatment. One thing that we do and we see every day in EMS and in emergency medicine in the hospitals is that we call stroke alerts, and we call trauma alerts, and we call STEMI alerts or cardiac alerts. And many hospitals have started calling stroke alerts. Some have not. But I think we're missing the boat if we're not treating sepsis as a time-dependent condition, just like STEMI or just like stroke. Some of the studies show that mortality from a stroke, acutely now, is only about 5%, and acutely across all comers, the mortality rate of a MI is only about 8%. But we put a lot of interest and a lot of work into cardiac alerts, STEMI alerts, and we should. I'm not saying we shouldn't, but if you look at the 8% and the 5%, and then you look at the mortality rate from sepsis of 40%, then again, we certainly have a lot of work to do in order to capture those patients and get the proper treatment for those patients in a time-dependent form. Sepsis is on a progression or a continuum, and it starts out with what we call SIRS, which is systemic inflammatory response syndrome. Some of these things that make up the SIRS we can measure in the field, some we can't. But as a general rule, it's a systemic inflammatory response. It's sort of the precursor of sepsis. The body's starting to rev up their immune system to sort of arrest that infection. Some of the things that go into SIRS and sort of a definition of SIRS is a temperature is greater than 100.4 or less than 96.8. And that's important because some people, especially elderly people, may not be able to mount a febrile response, so they may actually be hypothermic. Respiratory rate's greater than 20, heart rate's greater than 90. Something we can't usually test in the field, but white blood count's greater than 12,000 or less than 4,000, or greater than 10% bands. And bands are a sort of a immature form of white blood cells. As the body starts to realize that there's an infection and trying to arrest that infection, the bone marrow, if the bone marrow is able, will start to churn out immature white blood cell forms, and those are what we call bands. So if you look at a blood count, and again, we don't do this in the field, but if you look at a blood count and they're greater than 10% bands, it's what we call a bandemia. and that's significant in somebody that you're worried about sepsis. PCO2 is usually less than 32. So if we have SIRS on the low end of the spectrum, and then there's sort of 4 steps, we move into sepsis, which is the next step, and that's 2 of the SIRS criteria, as I just mentioned, plus a confirmed or suspected infection. And then from there we move into severe sepsis, which is sepsis plus signs of end organ damage. We don't measure it in the field, but they got decreased renal function. Something we can measure is that, mental status changes, hypotension, blood pressure less than 90 systolic. Lactate we don't really measure in the field. Some systems do, but lactate's greater than 4. If you remember, lactate is a measure of anaerobic metabolism. That means that the body's not really getting the substrate it needs to really have aerobic metabolism, so it's anaerobic metabolism. And then the end result is what we call septic shock, and this is severe sepsis plus persistent hypotension, persistent end organ damage, persistent lactate greater than 4 despite all the treatment. So again, it goes from SIRS to sepsis to severe sepsis to septic shock. Once you get up to septic shock, as I mentioned, that person is hypotensive, and even with severe sepsis, the patient is hypotensive, that mortality rate can be up to 40%. So that's huge. So what we need to do is arrest this process at the SIRS or the sepsis form rather than letting it progress. So pathophysiology of sepsis, as I mentioned, the sepsis is an exaggerated immune response. It's not just a typical response to an infection. Usually what happens, if you remember, on an infection, and think about when you have an infection on your arm or whatever, the body recognizes this an infection there. The body starts to increase blood flow to that area. You'll get a little bit of capillary leak because the endothelium of the capillaries are a little bit damaged, and you start to leak some fluid out, and you get some swelling, and you get some redness because of the increased blood flow, and you get what we call mediators, cell mediators. Basically, these are chemicals that the body releases to sort of, for lack of a better term, sort of wall off that infection and help fight that infection. Well, that endothelium that's damaged and cell mediators, usually that goes away pretty quickly, and that endothelium is healed pretty quickly. But in sepsis, you get all of that, but it's an exaggerated response, and that endothelium becomes more damaged, and that endothelium doesn't heal. You get a coagulation issue because the body normally has sort of a homeostasis of coagulation, but all of a sudden the body starts to have a coagulation issue, and you start to have, you can actually go into DIC. You get vasodilation of the capillaries because of the exaggerated response, and that's what leads to hypotension. And then at the end result, you get organ death. So sepsis goes beyond the normal infection response. It's an exaggerated response. So again, we need to recognize some of the early signs of this and how to arrest that progression from SIRS to septic shock. Again, going back a little bit and talking about SIRS, we don't routinely measure some of the things that make up the SIRS definition in the field, but we can measure the temp. We can measure the heart rate. Again, heart rate greater than 90. We do measure the respiratory rate less than 20. Greater than 20, and the mental status changes. So those are things that we can measure. Again, high index of suspicion. We need to make sure that we're thinking of septic patients when we see these patients that are have a fever, sort of altered mental status, they're hypotensive, etc. So what are some of the risk factors of sepsis? Well, older people, younger people, people at extremes of age. Some people will tell you that people who are patients who are unable to communicate, you have to go over them with a fine-tooth comb. because these people may not be able to tell you exactly what's wrong, and you may miss an early septic patient. But recent surgeries, recent pregnancy, recent childbirth, recent illness, people who have an immune system that is compromised, the diabetics, the cirrhosis of the liver patients, HIV, sickle cell, lupus patients, people on chronic steroids, people on chemotherapy, recent antibiotics, they've been sick, the bedridden patient, the nursing home patient, indwelling catheters, all those people are at risk for sepsis. So what are the signs and symptoms of sepsis? Again, fever, but not always will we have a fever, especially in the older person. Even in the infant and the neonate, we may actually have hypotension. So hypotension, hypothermia is just as important as hyperthermia in somebody that we're concerned about sepsis. Chills, shaking, nausea, vomiting, mental status changes, think flu-like symptoms, and again, hypotension is a late finding. So those are signs and symptoms. So how do we improve sepsis mortality from the EMS standpoint? I will tell you that we can make a difference. This is not a patient that we just pick up and move to the hospital. We need to rapidly identify those patients that we think are either at the surge level, or hopefully we get them before they get to that sepsis and severe sepsis and septic shock. But rapid identification. Fluids are the mainstay of what we do in the pre-hospital arena. Timely antibiotics. I know that we don't carry antibiotics routinely in the field. In Alabama, some systems do. We may go to that at some point in time, but we're certainly not at that point now. The federal partners have developed what we call care bundles, and basically these are just order sets with IV fluids, specific antibiotics for specific types of infection, etc. We use those every day in the hospital. So, and they have been shown to improve the mortality from sepsis. Sepsis alerts that I talked about. These are teams in the hospital. The sepsis team are teams in the hospital that approach a septic patient just like a STEMI patient, just like a stroke patient, just like a trauma patient. And these hospitals that have used sepsis alerts have shown that there's decreased mortality in these patients, decreased hospital stays. So I think sepsis alerts in the hospitals are something that every hospital should use. I think we should move toward that. So recent studies have shown that aggressive fluid resuscitation from the field is what we really need to focus on. If you look at some of the studies, 34% of the most critically ill patients arrive in the emergency department by EMS. So 34%. So we have a huge opportunity to affect change in those patients that are seriously ill. And again, we're seeing more and more septic patients. So something that I would suggest, just high index suspicion and IV fluids. So one of the things that I think that we, again, going back, we can decrease the time to the IV fluids. And you may think, well, 15 minutes of transporting a patient to the hospital, is that 15 minutes really going to make a difference? It will. I certainly think that 15 minutes fluid resuscitation can certainly make a difference in these patients. Again, some systems will use antibiotics, as we talked about. So I think if those systems that are using antibiotics, there's a decreased time to antibiotics. So from our standpoint, we always follow the ABCs, our airways and our, the A and the B, non-rebreather, possible CPAP, possible intubation if they need intubation. And then from the circulatory standpoint, large bore IVs, and don't be afraid to give these people the fluids that they need. The standard is 30 milliliters per kilogram of IV fluids. That's a lot of IV fluids. Some of these people are getting 3,000, 3,500 milliliters of fluid. Some people get a little bit nervous when they're giving that much fluid. But these people are getting that. Now with obese patients, we're actually using ideal body weight to figure that 30 milliliters per kilogram, but still, sometimes that's a lot of fluid. Now some people will ask, well, what about these people that are fluid sensitive, the CHF patients, the cirrhosis of the liver patients? what I have found that works very well is I will figure out how much fluid they really need, and then I'll give them a 500 cc bolus. I'll watch them, make sure they're not developing signs and symptoms of congestive heart failure, pulmonary edema, and then I'll give them another 500 cc, and I continue to do that. And over about 20 or 30 minutes, 45 minutes, I've given them that 2,500, 3,000 cc's, but I've continued to watch them to make sure they're not developing pulmonary edema. So I think that's important to do as well. One of the things I talked about with the sepsis alerts, I think it's important that we call ahead to the hospital, let them know that we've got a patient that we're really concerned about sepsis with. Even if the hospital is not doing the sepsis alert, I think we need to do our part and notify the hospital and give them the report that I think I have a septic patient, so that they can get their team mobilized to take care of that patient. What about that patient that you've given the fluids and they're not improving, and you need to go to the pressors? Well, again, as I talked about, 40% of those patients that become hypotensive probably are going to die, especially if they're an older patient. Well, routinely we carry dopamine here, and if that's the only thing you got, then I think you need to use the dopamine. But once you get to the hospital, many times we're using Levophed. I think Levophed is a better drug than dopamine. Most people will tell you that probably ought to use Levophed rather than dopamine. And one of the reasons that people are steering away from dopamine is dopamine has been shown to have a higher increase or higher instance of dysrhythmias, and especially tachydysrhythmias. And these people are critically ill, and they really can't stand another insult. But again, if that's the only thing they got is dopamine, then use dopamine. But don't be surprised that when you get to the hospital, don't get your feelings hurt. They may change from dopamine into Levophed. It's nothing that you did wrong. It's probably a better drug. So I think in recapping with sepsis is something that we as EMS professionals can certainly sort of help the patient long term. High index of suspicion. I can't stress that enough. If you're not looking for sepsis, you're not going to find sepsis. So look for sepsis. Look for those SIRS criteria that we can measure in the field. The heart rate, the respiratory rate, the mental status changes. And hopefully you can arrest that progression before it gets to the more severe form of sepsis on that continuum. And from our standpoint, fluids. Don't be afraid to give that 30 milliliters per kilogram of IV fluids. And again, if they're elderly, they have a problem with fluid buildup, the congestive heart failure patients, etc., then don't be afraid to give that total fluid as 500 milliliter boluses and watch them. You're with the patient, especially on these long transports. Notify the hospital that you've got a septic patient. If the hospital is actually using sepsis alerts, then by all means tell them that you think you have a sepsis alert. And just don't ever think that what we're doing for sepsis doesn't matter, because what we're doing in the field can certainly make a difference and decrease mortality in the septic patient.